Hello and welcome. I'm Art Plank, President and CEO of MDI Hospital. This is the third in a series of virtual town halls that we're hosting to keep our community informed about COVID-19. As of today, the Maine CDC is reporting 5,171 cases of COVID-19 in our state and 53 in Hancock County. And unfortunately, Johns Hopkins is reporting 6.9 million cases in the United States, and there's 31.6 million cases worldwide. So as this global crisis continues, MDI Hospital and our communities are very fortunate to have such highly educated, skilled, and dedicated caregivers. Today, you'll hear from 3 practitioners who are at the forefront of our coronavirus prevention efforts at MDI Hospital. Kate Worcester and Dr. J.R. Krevans, and Dr. Julian Kuffler. Kate Worcester is a certified physician assistant who has been our primary testing practitioner and has taken a lead role in counseling and providing contact tracing assistance to residents and visitors. J.R. Krevans is the chair of our Infection Control Committee at MDI Hospital and has been a guiding force for our COVID-19 preparedness response. He has an extensive background in public health, emergency preparedness, and the management of infectious disease. And Dr. Julian Kuffler is the Director of Medical Education at MDI Hospital. Dr. Kuffler is leading our community COVID-19 prevention and education efforts and has an extensive background in public health, care coordination, and medical education. As we work to address the COVID-19 pandemic in our community, MDI Hospital has focused on providing as much information, education, and support to the community as possible. In our partnership with the Down East COVID-19 Task Force, we're working to support our schools by procuring additional PPE and providing education, guidance, and resources. We've established a pilot program for asymptomatic workforce testing with the hope that it is continuing to serve as a model for other seasonal communities. And we've launched a medical grade masking education and distribution project to ensure that all area businesses have the tools they need to provide the highest level of protection. So today, we'll discuss the flu and COVID-19, testing, managing potential exposure, workplace safety, educational guidelines, and address your questions, submitted in advance, and hopefully some asked today. So if you'd like to ask a question during the discussion, please use the Q&A feature located in the bottom panel of your Zoom screen. So we'll answer as many questions as possible with time permitting, and those that we don't have time to address will be followed up via email after the event. So why don't we get things kicked off by talking about testing a little bit. Kate, you've been at the forefront of this from the beginning. What's the current turnaround time for receiving coronavirus test results?
Yes, thanks, Art. The current turnaround time is approximately 2 to 3 days. These tests are being sent to Quest. They are sent out in the afternoon. We usually receive the results back approximately 48 hours after the sample itself reaches the actual lab. We get these results back and the patient gets their information and their test results back approximately 2 to 3 days later.
Okay, so if someone were to come up to you and say, I think I was exposed to someone who's tested positive, what should they do? What should I do?
The CDC is a very nice guide for those that come into contact and have a think versus I know. If you think you have possibly been in contact with someone with COVID-19, the recommendation is no indication for quarantine, but you should be symptom monitoring yourself for 14 days. minimizing your risk clearly to any exposures to others as much as possible, but you're more symptom monitoring than actually, there's no quarantine actually indicated. If you were to come into contact with someone that you know was tested positive for COVID-19, that's when you have a 14-day quarantine. Also during that period of time, you're going to have 14 days of symptom monitoring. You would also be contacted by the state CDC as well as someone from the hospital if they felt that you were in direct contact with someone with a positive COVID-19 test.
Okay. So is there a common way in which the contact tracing process is managed and handled? Julian, I know somebody came up to you and asked about a community concern that a few people had.
Well, I think you could look at this in a number of different ways. One, any discussion between a patient and their provider is private and not shared. We have been working very closely with the CDC around the issues of high concern, either an exposure. They have a well-developed contact tracing program. We've certainly watched it being used here on the island. So I think that if someone is worried about whether they have been exposed to a known positive COVID patient, the CDC will be in touch with you. The fact that they're not in touch with you, you should take as a good sign. It's also not to say that if you don't start developing symptoms that you are concerned may or may not be related to COVID. That's why we have a COVID hotline. That's why we have readily available testing.
That's great. Thank you. So one of the other common discussions that folks have been asking us about is issues related to the school opening. And JR, is it safe to be handling shared items in school, like paper and electronic art supplies, those kinds of things?
So I guess I'm going to back up before I start talking directly about that and talk a little bit about transmission in general and a little bit about risk in general. We're not going to be in a risk-free environment. The goal is to figure out what's an acceptable risk for an acceptable benefit. We're going to take a little bit of risk to get kids back into school. But then you want to say, what are the real risks versus the things that, gee, it might be a tiny risk, but we don't want to waste time and thought about that. So what we do know is that transmission on surfaces is a very poor way to spread coronavirus. One of the interesting things about coronavirus is while it's a very dangerous virus, it takes a fair, you don't get coronavirus disease if you get 1 or 2 virus particles in you. So if somebody touches a counter and then an hour later you touch that counter and then you pick up a sandwich after washing your hands, you're not going to get it. But around shared objects, at one extreme would be pencils, at least if I've got the pencil. Because if you may remember, people who are thinking and have forgotten how to spell I before E, they put the pencil, the back of the pencil, in their mouth. And just watch kids if you don't believe me. So something like that, I would say, would not be something I would, that probably ought to be kept to one person. In a matter of a few hours, the number of germs on an object drops drastically. In a couple days, it drops to 0. If you wipe it down with almost any standard cleaner, alcohol, standard spray cleaners, whatever, it's incredibly effective. Basically, everything we've tested works. The papers, I would say, are a very low risk. Interestingly, I did, in preparation for this, go on state, federal, World Health Organization, CDC websites, and everyone says, gee, it could spread on surfaces, but it's very rare. And the actual studies have shown that there's almost no documented cases, and they're generally things like medical items that were in a patient's room with a critically ill patient, not something that was around a low risk person. So I would not put a lot of effort there, but I would avoid things that are going to go into people's mouths. As opposed to, say, ventilation, which is a much bigger issue that we're hearing a lot about nowadays. And it's droplet spread and smaller particles, airborne spread. And that's where people really need to be spending over 99% of their thought, is on those issues. Also, by the way, if people are wearing masks, they stick things in their mouth a lot less, and they don't contaminate surfaces very much either.
It's hard to stick something in your mouth when you're wearing a mask. That's very true. So from a workplace safety perspective, is the ventilation system one of the primary things that employers could look at?
Yeah, so in terms of what we know works, the biggest single thing, of course, is universal masking, because that both protects you and it also just decreases contamination of the environment enormously. And everything around that is primary. After that come two related things, which is avoiding air, droplets from one person getting to another, one of which is spacing. Is it possible to have people, 6 feet apart is better than 3 feet? That's actually been looked at in some nice European studies. And then if you have closed spaces, you want to exhaust the air. If there's multiple people sharing a closed space. And by exhaust the air, we're talking about windows open on two sides. We'll usually do it. It's getting a little late in the year for that. Exhaust fans in a window will work, and then pull air through the system. One thing that doesn't work is having a fan that circulates the air in the room. Blowing the air around in circles in the room may make people feel like they're doing something, but actually it just sort of spreads it over a larger distance. And so you do want to avoid that. A lot of the schools and businesses have been working quite a bit on these things over the last few months, trying to be more ready. The reality is we're going to be ventilating more into the open air this year. There's going to be a lot more heating oil used this year, and I don't see any way around that. But that is a real benefit.
So one of the things that, yes, sorry, Kate. So one of the things that we I know have been talking about around the hospital has been the new challenge that we know we're going to be dealing with as the fall arrives, and that's the normal influenza season. So Julian, are the flu shots currently available in our clinics at this point?
Currently, flu shots are available in the clinic. You call, you make an appointment. You don't have to wait. You come in, you go, you get your immunization. The important issue this year is that flu as well as COVID both attack the immune system. We know that people who get the flu can often get very sick. And they can get secondary infections. The last thing we want people to do is to have the flu and then get COVID. We unfortunately know that you increase the potential death rate from COVID by 50%, or you almost double the death rate of COVID if you have flu. The other good reason to get a flu shot is that if everyone gets protected from the flu, we will have that many fewer patients on the island who have fevers. And fevers is a really good indication to go be checked out for COVID. If we don't have those folks getting the flu, we're going to be doing less symptomatic checking and testing. So I think those three issues really should drive people to say, if you haven't gotten flu shots before, this is the year to do that. I wish we could say that flu shots are 100% effective, but it only covers for the 3 or 4 different strains of flu that they feel are most likely to be in the community this year. But I'd rather be 70% protected than 0% protected.
Thank you. So Kate, as we start to get into the flu season, what kind of new challenges does that present for our screeners and those people who are working to make sure that people get the care they need?
It creates a huge challenge. I mean, clearly the symptoms of influenza and the symptoms of COVID-19 are very similar. We're doing our very best. The COVID-10 team is an outstanding team that has worked together. We've been doing this together for about 6 months now, trying to triage through and determine when testing is appropriate. Right now at our hospital, if you have symptoms of COVID-19, you are tested. You're tested through our testing tent, which will be transitioning to a different location after it has been closed. The testing itself, we're doing on any symptomatic patient, you're having a nasopharyngeal swab. We are gathering that here and then it is sent out. One of the questions I saw that had come through was whether or not we call with the results on patients. Because there's different providers each day, we have tried to really make it universal with what we're giving for information so that patients are getting the same piece of feedback with their symptoms. They're oftentimes being encouraged to symptom monitor for 24 to 48 hours. That's going to be really important during influenza season because we really want you to monitor your symptoms, keep us updated on how you're doing so that we're testing patients when they're more symptomatic or more highly suspicious of COVID-19 because it is therefore more sensitive, the test itself. I myself, I'm the primary testing provider. I can't speak for all the other providers. We do try to make a direct phone call to every patient who is tested. Our medical assistants have had to take over some of that for us because of the volume of testing that we're doing. If test results come back on weekends, I do weekend coverage, and all patients that were symptomatic that were tested, that were sent to Quest, which is our primary lab where we're sending our tests at this time, I contact even over the weekend with their results. I know many people are anxious to get back to work and need to get back to their lives and need to know those results. So we do try to really expedite those phone calls back to patients. Patients can call in though to the hotline if they're wondering where the results are. The hotline that is answered by nurses through our care management department, and they are now giving results to the patient. Those are all negative results. Any result that comes back that is positive, the provider who did the swab itself, that provider does contact the patient, as does the state. So it's usually within a few hours of each other. So, but the negative results are given by our care management department as well as through the COVID tent staff that works in the pavilion.
Okay, thank you. So Of course, the ultimate solution for all of this would be the 100% effective vaccine. JR, you've been following that research closely. Where do you see things at this point?
So I think that, well, probably one question first would be the timeline question. And in the last week, there have been a couple things. Something that was actually, I mentioned at the last town hall, is there's been some question in the big British trials about the possibility of neurologic side effects of the British vaccine, which many people thought would be ready first. Some of the trial sites have restarted, but the Food and Drug Administration has told them that they are not satisfied, that they are ready to restart in this country. Additionally, it's about 36 hours ago now, the FDA put out some preliminary draft discussion, not more than discussion, their plan on how they would, what they're expecting for vaccine evaluation. It basically saying that while many things about the process in terms of pre-manufacture, recruitment of subjects, timelines of data submission have been speeded up, they are going to use all their standard protocols and timelines in the evaluation of the vaccine, including that for the American trials, they're expecting that all the subjects will be observed for 2 months after their second dose, and the doses were given a month apart. So we're looking at 3 months from the end of recruitment, which was, I think, mid-September, before we might be seeing a potential approval. And the FDA says when they do it, it's going to be a formal approval. It will not be an EUA. So I find that very reassuring that they're being very clear at the CDC and FDA level about how they're going to do it. But it does mean that I don't think we're looking at any likelihood of something being in general use until around Christmas at the earliest. Beyond that, there's the question of how much it's truly going to be available in what order. And so probably there will be enough vaccine for medical care personnel and high-risk individuals in high-risk locations. In other words, older people with pre-existing conditions in Mississippi or Nebraska, which are hotspots right now. Probably we would not be getting vaccine except for our healthcare workers and our emergency services workers initially. So we're looking well into next year. And then the big question in terms of efficacy is a vaccine will be accepted if it is 50% effective, which means that it will really decrease the spread in the community, but won't offer perfect protection to a high-risk individual. And then the final question is duration of protection. There was just a study that came out this morning looking at people who were mildly infected, several hundred, and their protective antibodies waned significantly over a period of several months. More like what we see with typical coronavirus and the flu, which is problematic because it does suggest that this may be a vaccine that needs a booster. So some positive things in terms of process that I think it's going to be, looks like there's a strong intent to handle it safely. And some positive things in terms of, I think, timeline. If we can have it by this winter, that's unbelievably fast from my perspective. But whether or not it's going to be a complete game changer or something that's sort of part of the package of what makes us better able to function is not clear yet.
So part of the mix of approaches to mitigate the spread of the virus has been to discuss different forms of testing, and particularly as we talk about it, whether people have immunity or not. What kind of testing, Kate, can you tell us what kind of testing is available at the hospital today?
We presently do not have antibody testing that is accurate. When we have been made this available, we certainly will let the public know. But right now, we do not offer antibody testing. We are doing our PCR, so that's what we're doing for testing. We do have rapid testing available that is kept for patients that need that urgently, whether hospitalized, transfers, patients need to have emergent surgery. We do have a separate SEPID machine that we use for that. For our community members that are symptomatic, it is the PCR, the nasopharyngeal that we are doing for testing. But as of yet, we do not have the antibody testing that is specific to COVID-19. I think JR could probably comment a little bit more on why there is that delay for the antibody testing, and why we want to make sure it's accurate when we do make it available, that it truly is going to give you feedback that is going to be directly related to whether or not you have a level of immunity or not.
Yeah, so there was a whole bunch of interest in antibody testing earlier in the summer. Almost all of the antibody tests that were initially authorized, I won't say approved because actually it was a non-standard process, have now been pulled off the market because of inaccuracy. But the bigger issue, even with an accurate antibody test, is to try and determine what antibody tests truly predict that you will not get disease, or more interestingly, that you will not spread disease. So it may be that antibodies will protect you from becoming very sick yourself, but might still allow you to become a spreader in the community. There's a lot of research around that right now. The last thing I read from the FDA suggested that they may be suggesting a combination of antibodies. One antibody, which is very specific for coronavirus, SARS-CoV-2, and other antibodies that are better at predicting, is this real immunity or not? There is not a well-defined panel that would enable me to say to somebody, your antibody test means you are safe for the next 4 months. That's what we're looking for. And we don't have that. It's a good research tool if we want to know what percentage of people on Mount Desert Island have had coronavirus already. There are some good antibody tests from a research basis that say about this many people. They're not precise. 3% or 7% or whatever of our population have been infected sometime in the last 6 months. But that's different from knowing if you, Art Blank, were really one of those people, and if you were, could you get it again?
Has yet to determine how long that level of immunity lasts as well. If somebody were to antibody test positive, it's unclear right now what the length of that immunity is, and how good of it's actually protecting you from future infection. I think JR and I've talked about that the likelihood of having a more severe form of it later on is less. We don't know yet how long you have that level of immunity if you did contract, COVID-19, how long you have immunity after that, the period after.
Interesting. So will we have a sense of that? Is that part of the criteria when they're doing these trials to provide some data as to how long we think immunity will last? So should we have a sense of that when the vaccine becomes available?
I think to say we'll have a sense of it is reasonable. The reality is, we are not yet a year from the first cases in humans that we know of. We're 9 months from the first cases in the United States, diagnosed cases. So we just don't have a lot of data yet on reinfection. There are definitely have been a few cases, but it's looking like 6 months at least. based upon some very soft data. But I won't be able to tell you a year until 6 months from now. So we're going to be continuously riding that question until we're a long ways out. One question I want to pull off the screen, because people are talking about, what do we know about infection and immunity? Someone's asking about the current status on the island and the rates of infection. Our rates here are very, very low. We have a pretty good idea, partly because even though we're a low risk area, we have a very relatively high testing rate. It's relatively available. And if somebody from our area gets tested elsewhere, then we get that information will show back up on the state's dashboard. So we are seeing much less than 1 case a week here on the island. And we don't think it was significantly affected by tourism. There has been a suggestion in 1 or 2 cases, but actually we have not seen either multiple symptomatic people, and we're 800, 900 tests into our front-facing worker screening program, and we have not had any positives. And the Jackson lab is several thousand tests into its screening program, and they have not had any surprise positives either. So right now, we are in a very good situation. It'd be really nice to keep it that way.
Great. And that's a great segue. You're much better at multitasking than I in terms of getting to the questions. I'm sorry, Julian, did you have something you wanted to say?
I think that just looking at how lucky we have been this summer here, I think this community has done exceptionally well in trying to be proactive in terms of preventing the onset of COVID-19. We've seen no indication of community spread. There was a terrific coalition that was brought together, and it continues to meet. It's been made up of the towns, the managers, business community, Chamber of Commerce, hospital, Jackson Lab, Biolab, COA, public schools, national park, all working together. The beginning of this summer, there was very little, if anyone, wearing a mask walking down Main Street in Bar Harbor. Now, the vast, vast majority are masked. The ability to stay socially distant, I think, has really improved. So we should be proud of all of that. I think that the biggest thing we need to be aware of is that this is not going to be over until there really is a good, effective vaccine that's tested and available to everybody. So I think that it's nice, as JR said, we haven't seen a lot of infection being brought in from away, but that is forever a risk. And I think if friends contact and say, I want to come up here and be on MDI because it's very safe, we need to inform them that they have a responsibility. If they come from a state that has a higher incidence than we do, having them get a test before they show up makes a whole lot of sense for all of us. And if not, then they ought to get a room with a view, because they're going to be looking out the window for 2 weeks. If we get community spread from someone who innocently brings it in, we're really going to seriously affect our ability to continue to open up the schools, to continue to expand businesses. So we should congratulate ourselves, but we have to stay vigilant.
So I do want to make sure we get a chance to answer some of the other questions, and I see that there are questions out there. Danielle?
Yes, absolutely. Will testing capacity in the state improve, and if so, when?
I think It has yet to be determined. Did that question go to me?
You can?
It's based on the labs and the capacity as to how much they can take. On top of that, are testing kits that we're supplied with. And that is, certainly something that is variable. It's out of our control at this time. Presently, we're not offering any asymptomatic testing here at MDI Hospital because we don't have enough test kits to do that and make it widely available. Initially, Northern Light was doing asymptomatic testing, but is not able to do that now because it was just the capacity is too high. Anyone who is looking for asymptomatic testing, they're being referred to Convenient MD in Brewer. You do have to have an appointment. The turnaround time is around 2 days, is what I'm told. They also do it at York County Hospital. Getting an appointment, I'm told right now, is approximately two weeks away. So it's by no means a rapid way of getting asymptomatic testing done. We're in hopes that that will change, that we will be able to open up and do more testing. That certainly would be what would be best, but we're working with what we have for supply and with the government and the state to do our very best.
JR?
Yeah, I think what people need to understand is that this is a national issue, and that because of the outbreaks in other parts of the country that have not chosen to control the outbreak, their supplies are being diverted from the states which have chosen to control the outbreak to other locations. So for example, our hospital has not one, but 2 pieces of equipment that would enable us to do significant amounts of testing here on the island. One of them we have no ability to get resupplies for, and the other we have been told that starting sometime soon, we will get a highly rationed number of tests. But we don't have a definite date on that, but it'll probably be actually sometime. But we're talking about like 3 a day, not talking about like, 200 tests, for a screening program a day. And that's really the issue. Possibly a couple months down the road, we may be looking at reasonably accurate rapid antigen tests, like a pregnancy test type test that could use saliva. There's some that are in the approval process that have reasonable looking numbers and preliminary data. But then once they're approved, then it'll be the issue of when the manufacturers are able to produce them in significant numbers. I am hopeful because one of the manufacturers who's getting approval for that is actually a Maine-based company. And they're going to manufacture them in Portland. So I'm hoping we might have a better shot at it. But that's a hope, not a promise.
Yep.
Oh, and I should mention, even sometimes getting the swabs to do the test is not possible.
Yeah, I mean, I can add, one of the challenges that we continue to have is any supply that's related in any way to managing the COVID crisis is very challenging. Be it anywhere from gloves to gowns to testing supplies to even the vials that the test samples need to be stored in. And so when we talk about the turnaround times and all these other kinds of things, these things actually do change day to day. So whatever you hear today is the best information that we can provide to you. But we are monitoring it on a day-to-day basis. And one of the things particularly Kate spends a lot of time doing is trying to figure out where the most efficient place is to send a particular sample so that we can get the best turnaround time for our community. So it is a challenge, but and hopefully we're 6 months into this now, and hopefully some of those shortages will be alleviated at some point soon. Danielle?
Another question that came in is, what should community members be thinking about in terms of protections and indoor air quality as the colder weather approaches?
Okay. Julie, I know we've talked a lot about that. You want to take that one?
I think that, again, the basic things that we've been saying from the very beginning, masks really help. When you go out and you're going to be in contact with other people, you've got to have a mask on. The more that you can stay 6 feet, 8 feet, 10 feet away from people, the lower your risk. I think that if you're going to go into closed spaces, there's got to be, you look around, there's got to be a window open, there's got to be something exhausting the potentially infected air out of that building. I think in your own home, turning the air quality over on a regular basis makes sense. But let's go back to the mask, the hand washing, the distance. It's got us this far. Let's not let up. I would also say that let's keep the home front safe. Limit the number of people who come into your home. If you have been in your home with your family and you are well, keep it that way. Take a lot of rain checks.
Julian, I do have a little bit of a follow-up question that goes along with that. With the fall season upon us and restaurants that offer outdoor dining dwindling, do you anticipate that the risk of indoor dining of COVID-19 exposure for patrons, and importantly for servers, will increase? And also, will MDI continue its program of surveillance for public-facing workers?
You know, there is data that says that people who eat out at restaurants have a higher likelihood of getting an infection. I think that restaurants that want to stay open should seriously be looking at air exchange, because that's going to markedly diminish that risk. The other part of the question, sorry.
Will MDI continue its program of surveillance for its public-facing workers?
I think I'll take that question if I could.
Good.
And it's because we're still quite frankly working on that. As Kate mentioned, we do need to close our testing pavilion. It is an outdoor tent, and outdoor tents are wonderful in July and not quite so good in December and January. And we have been working very actively, really on two fronts, both trying to make sure that we have the testing facilities that we need in the colder weather, but also making sure that we can accommodate in a safe environment the kinds of patient flow that we will have during those fall and winter months as well, because going back to the discussion that we had earlier about flu season, it will change the nature of some of the care that we need to receive throughout our system, provide rather throughout our system. So I can assure you that those things are being actively worked on, and the level of asymptomatic surveillance testing that we'll be able to do will be directly related to what we assess as our capacity to do that work. The current pilot project was designed to end in the middle of October. I think we do have some plans to at least for those employees that are continuing to be engaged to extend that a little bit. But in terms of a year-round program, we will be letting you know as we assess the capacity that we have for that kind of testing.
I just wanted to add one other issue around restaurants. If you have a favorite restaurant and you are concerned about indoor dining, just remember, support them with takeout. You can eat just as their delicious food at home. until you've decided that they have made the precautions so that indoor dining is safe.
All right, another question that came in. Why are college campuses considered different than elementary and high schools in terms of testing recommendations?
Who'd like to take that one?
I can, what I've found in talking with schools versus colleges versus businesses is each, site, they have their own regulations and they're making their own set of rules. This is new and they're trying to keep their patients safe. They're trying to keep their students safe. They're trying to keep everyone safe. Why there are different rules for schools versus colleges. I know a lot of the college students can learn remotely, where the younger kids do need more in-person education and that closer one-to-one contact. Some of those campuses and colleges are opening and they are having students come back. They have specific testing guidelines that they are making available according to their testing capacity, according to where that college is, how high the risk and their positivity is in that community versus somewhere like here where our positivity rate is so low. That's where we're really much more supportive of trying to get kids back to school. So why those are different for each place, I think, is highly dependent upon where it is, who's being educated, what the age group is, and what the positivity rate is in that community.
Also, some colleges that are more residential in nature, what they've done is they've tried to organize the students into tight cohorts and aggressively screen the kids, quarantine the kids, and sometimes test the kids on arrival with a goal to try and create essentially a closed, safe community. In terms of, for a lot of college kids, the school is their socialization. It is their family. So you're trying to create a closed, safe family. And the way they do that is with a lot of testing up front. Other schools elsewhere in the country have made some very different choices. And you look at school, in looking at the big outbreak we're seeing now in the Midwest, it looks like one of the main drivers of that in many places has been reopening of colleges and college parties, and then people going back out into the community. These are also places where the people who work in stores and restaurants are generally not masked as well.
We ought to do a shout out for COA. They've done a terrific job. They have tested all of their students, have repeated the testing. They're very focused on this. So I wouldn't transfer the concern about what's going on nationally in colleges. At this point in time, COA is doing a stellar job.
All right, a question just came in that's pretty good timing for this time of year. What precautions should be taken around visits at Halloween?
So believe it or not, the CDC has Halloween guidance out there, which is actually pretty good. I'm astonished. There's certain things you cannot find on their website, but you can find detailed information about Halloween. And it's fairly useful in terms of sort of taking all the standard things we always talk about and applying them to Halloween. And there's actually the Down East Task Force a couple of weeks ago, even before the CDC started on this, we started to look at the question locally. What could we do, to try and preserve this community celebration? And also there's, what I'm going to say now also refers to a question that popped up on the screen about takeout food. There have been somewhere between very few and no documented cases of transmission via food. There are a couple questionable ones, but those people also had droplet exposure as well. So I don't particularly worry about, transmission on food that I buy, whether it's at the grocery store or takeout. It's just a matter of, make sure you and the person who's handing it to you are wearing masks when you get it. And that's also true of Halloween. So for Halloween, one thing is we need, the masks people need to be wearing need to be ones that protect against transmission, not decorative ones. Interestingly, there's a specific recommendation not to try and wear a decorative mask over a face covering mask, because they tend to interact poorly and either block the ability of they make your protective mask ride up or down and not work, or they may make it fit too tightly and actually impair ventilation. So that's actually a very specific recommendation. I thought I came up with a great new idea, but then somebody showed me someone else had with much fancier one. You could take a 5 or 6 foot piece of plastic pipe or cardboard tubing, put candy in one end and it slides out the other. It's quite a fun way to do it. Get a little bit of spacing. You need to think about keeping kids spaced apart. Family groups need to go together, not big clusters. This is like any other gathering. What you have to watch out for is a group of people who are normally separate, 4 or 5 separate families who normally keep apart, who suddenly get together at Halloween and you have all 27 kids mixing together. And if one of those is positive, you've got an issue. You're not going to have, ledge law, we're not going to have haunted houses with people going through people's houses. That doesn't make sense. We're not, Halloween, I think adult Halloween parties, to be honest, are going to be more of an issue for transmission than kids trick-or-treating. For the play, I know there's some towns on the island that do trunk or treat where they have a series of cars. Once again, it's, park the cars 10 feet apart, everybody wearing, protective type masks, and the adults need to restrain themselves from wandering between the cars and, chatting with their masks off, because that's actually what I'm more worried about in many ways. So anyhow, it's a fascinating, very good CDC site.
All right, I think that we have time for one last question. As the pandemic continues, the ongoing stress and uncertainty can be difficult to manage. What should community members do to help cope?
Jared, do you want to take this? I mean, I can say, oh, Jared, you're still muted.
Go ahead, Kate. What? I didn't quite follow the question.
I think the question, can you repeat the question, Danielle?
Yes. As the pandemic continues, the ongoing stress and uncertainty can be difficult to manage. What should community members do to cope?
It's a great question. One thing that, our community should know is that we're always here as a resource. You can call our COVID hotline, or you can call the COVID tent and speak with somebody 5 days a week. On the weekends, we have someone that's available to put phone calls through to a provider to talk you through your concerns. Many people express concerns as to whether or not they could have been exposed, whether their symptoms are worrisome, and whether they need to be tested. I spend the majority of my days talking with people about those very concerns. I know sometimes just answering those questions and giving them some public health and education and symptoms to watch for, when we could test them, why we would test them, why we wouldn't test them, offers a lot of stress relief. And just knowing the process, especially if it's the first time you become sick during influenza season, not knowing if you have influenza versus if you could have concerning symptoms for COVID, talking with a medical provider on the other end of the phone, it relieves a lot of that stress. I didn't realize earlier we were live when we talked about the I think piece, but there is a 24-hour reporting line that the CDC has. And I know Danielle shared the workplace safety guide. That number's at the bottom of it. If you have any concerns as to whether or not you could have been exposed to somebody with COVID-19, or you have a general question and it's 9 o'clock at night, you can call that line and you get a voice on the end of that line. I have used it many times myself, to answer questions in regards to patients needing assistance. That does go directly to the state, and they're looked at by the epidemiologist. Just from a hospital standpoint, though, I think having a medical provider available to answer those questions and get right back to you, which we're really trying to be efficient with, helps to alleviate a lot of those unanswered questions and worries.
I think everything that Kate said is very important. The other is that it is an incredibly stressful time, and that the typical ways that we relieve stress by going out to eat, get together with friends, talk, party, sing, dance, laugh, do all those things, they're not in the cards right now. But we are lucky we're on an island that has a great big national park. I think the more people get out, the more they walk, the more they practice some form of mindfulness, it'll help. And if the stress levels just don't seem to be settling down, we have an excellent behavioral health center. And there's nothing wrong with using it for short-term stressors that we all hope and are counting on will go away, but we have work to do between now and then. And those folks are ready and able to help.
Okay. Well, we're about at the end of our time, and I want to thank everyone so much for joining us this afternoon, and certainly want to thank our panelists for their time today. As you heard, MDI Hospital is committed to the safety of our community, and our overreaching goal in providing these town halls is to provide as much information and support and education as possible to help mitigate the spread of COVID-19 in our region. However, we can't possibly do this without you. We need your vigilance, your support for one another, and your awareness of the need for better testing, treatments, and vaccines. And although the incidence of COVID-19 in our community, as we've discussed, remains very low, we must continue to be hypervigilant in our precautions. So until the vaccine is available, wearing a mask or face covering, practicing physical distancing and hand washing, and avoiding crowded situations with poor ventilation continue to be the best things that we can do to protect ourselves and to protect each other and to protect our overall community. So again, I want to thank you so much for joining us today and for your ongoing commitment to the health of our community. Please know that if you asked a question that didn't get answered, you will receive an answer via email. And we will continue to keep you informed as this situation develops. And again, very much appreciate your time and your participation in this very important discussion today. So again, thank you.